Hello, a very good afternoon, everyone. Now we are going to learn about twin pregnancy. We will go step by step, understanding types of twin pregnancy, chorionicity, and the clinical points relevant to fetal medicine. There are two types of twinning. First one is dizygotic twins, and second is monozygotic twins. Dizygotic twins occurs when two ova fertilized by separate sperms develop into two separate zygotes. So all these pregnancies are DCDA, means dichorionic and diamniotic. Monozygotic twins occurs when single egg is fertilized by single sperm and there is formation of one zygote, and this zygote splits into two. This could be dichorionic diamniotic, monochorionic monoamniotic, monochorionic diamniotic, and conjoined monoamniotic. So the chorion CHOR or char. So this layer of the fetus forms by fourth day, amnion forms by eighth day, and embryonic disc development occurs at 14th day of gestation. Once tissue is differentiated, it is unaffected by future splitting. Now, what is chorionicity? Chorionicity is the important parameter which is used to identify monochorionic and dichorionic twin. There are different zygosity assessment, screening protocols, complications, frequency of follow-up, management decisions, which is based on chorionicity. So the incidence of dichorionic twins is around 80%, where they have chorions means placenta. So they have separate placentas and amniotic sacs, and they constitute around 80% of the total twins. While monochorionic twins are 20%, they also share placenta and can share amnion also, organs also, organ systems also. They constitute around 20%, and the complications are more commonly associated with monochorionic twins. Now, for the determination of chorionicity, we use ultrasound. We have two signs based on sonographic parameters known as the lambda sign and the T sign. Lambda sign is seen in dichorionic twins, while T sign is seen in monochorionic twins. First time to assign chorionicity in the first trimester is at 11 to 14 weeks of gestation, which offers a sensitivity of 100% and a specificity of 99.8%. So this is a lambda sign and this is T sign. Now, lambda sign diagnosis is 100% at 11 to 14 weeks, and it decreases when gestation advances, like 98% at 16 weeks, 86% at 20 weeks. Lambda sign may not be seen in 14% of targeted scans. So these dichorionic diamniotic twin gestation can be missed in 14% cases at 20 to 22 weeks of gestation scan or a targeted scan. The reason is that the 11-14 week scan is used to assign chorionicity in the first trimester because it detects all cases of dichorionic pregnancies. Now, dating is done using the parameters of a larger twin. If one twin is having more CRL, then this is used. So at 11 to 14 weeks, we use scan to date the pregnancy, to label the pregnancy, chorionicity, and do anti-NB scan to rule out trisomy 21. Now, coming to labeling of twins, we have already discussed this, that the sac which lies directly over the cervix is sac A, and the sac which lies opposite to the cervix is sac B, and it is not related to the head of the baby. You can see that head of the baby is more closer in sac B, but it is sac B, not sac A. So these labeling of twins is used to follow up the patients with subsequent scans if the twins are discordant. Now, complications unique to monochorionic twins. So, two issues can occur when the twins share single placenta. First is abnormal vascular communication between two fetuses within the placenta and unequal placental sharing. These abnormal vascular communications can cause twin-to-twin transfusion syndrome, twin anemia polycythemia sequence, and twins reverse arterial perfusion sequence. Unequal placental sharing leads to selective fetal growth restriction, means this is the abnormal vascular communication which can cause TTTS, TAPS, and TRAP, and this unequal placental sharing can lead to selective fetal growth restriction, where the twin which have a smaller placenta leads to selective FGR because it has lesser blood supply as compared to another twin. Now, abnormal vascular communication or twin to twin transfusion syndrome and TAPS. In 85% of the monochorionic twins, there are no complication due to equal blood transfusion, while 15% there is complication due to unequal transfusion. Unequal transfusion leads to TTTS and TAPS. TTTS culprit vessels are large arteries. So, in twin to twin transfusion syndrome, there is large arterial to venous communication with unbalanced connections, while TAPS culprit vessels are tiny peripheral arteries. So these are large and these are small artery to vein anastomosis. Now, placental angioarchitecture. Placental angioarchitecture, when an artery connects to a vein, the blood flow will be in one direction through AV anastomosis, means from artery to vein, because there is high pressure circulation in the artery and there is low pressure circulation in the vein. So, there is preferential flow from artery to vein. When an artery connects to an artery, the blood flow direction will be decided by the artery with more blood pressure. So, in arterioarterial anastomosis, blood direction is decided by the blood vessel having more blood pressure. And A to A anastomosis is a welcome sign in monochorionic twins since it equalizes placental blood flow. So it is a good sign. If arterioarterial anastomosis is present, it is usually equalizes placental blood flow. Hence, it is a welcome sign. Now consider B to A 3 AV connections and A to B 2 AV connections. So over a period of time, twin B ends up pumping in twin A and loses blood as twin A cannot push back more blood to twin B. AA anastomosis balances the circulation on either side. If there is not enough AA anastomosis, the twin will develop twin to twin transfusion syndrome and the TAPS. So, what is Quintero staging? This staging is used to stage the twin to twin transfusion syndrome or the anastomosis and the findings. So, there are 4 stages. So there are 5 stages in Quintero staging. Stage 1 is twin oligo polysequence or TOPS. Here there is transfusion of blood from one twin to another and the recipient, that is baby, getting more blood, try to reduce blood volume by increasing the urine output, leading to increased renal blood flow, increased GFR, increased urine and polyhydramnios, while the donor twin will have oligohydramnios. So in this sequence, the twin which is donating blood will have oligohydramnios and the twin which is receiving blood will have polyhydramnios. Endocrine factors like ANP, RAS also play a role. In stage 2, there is absence of bladder in the donor fetus as blood volume is already reduced. So, this oligo leading to no visible bladder, and in the recipient twin there is distended bladder. So, B for second. So, in this stage, bladder is absent. In this stage, there is TOPS. Stage 3 is when critically abnormal. So, in this stage, Dopplers are abnormal. Either there is absent or reverse diastolic flow in umbilical arteries or abnormalities in ductus venosus flow. Stage 4 involves heart failure leading to hydrops due to cardiac failure, that is accumulation of fluid in more than one compartment of the baby. Hydrops is more common in the recipient twin. So, for one twin is having heart failure and the second twin which is getting the blood is having hydrops. So, there is 2 findings, H and H. Hydrops in one twin and heart failure in the another twin. And then there is stage 4 where one fetus is dead and there is high mortality of co-twin as well. Now, what is treatment of twin to twin transfusion syndrome? In stage 1, 50% will treat themselves and does not progress. Through arterial anastomosis balancing, they can treat themselves. Stage 2 or more requires treatment as there is 80 to 90% chance of losing both the babies. Now, there is one option where we can create a vascular equator or fetoscopic laser surgery can be done which blocks the anastomosis by fetoscopic laser. Aim is to ablate the anastomosis and dichorionize the monochorionic placenta. Has 65% chance to save both the babies and 80 to 85% chance of at least one twin surviving. So in this way we used to block these anastomosis using laser, and we do laser in such a way that a vascular equator is used. This technique is known as Solomon's technique. The risk of preterm labor in this fetoscopic laser surgery is 10 to 15%, and there is risk of premature rupture of membrane and IUD, even IUD also. Next is TRAP. TRAP is twin reverse arterial perfusion sequence. The culprit vessel is abnormal. So in TRAP there is abnormal AA connections. Rare complication unique to a subset of monochorionic twins. Here cord insertion is less than 15 centimeters. 80% of the twins have single umbilical artery and large arterioarterial anastomosis is seen. Impure blood from umbilical artery of pump twin flows into cardiac a cardiac or perfused twin through arterioarterial anastomosis, and there is impaired growth in perfused twin. So these are the types of acardiac twin. First one is so this is acephalus, acormus, amorphous, anidius, anceps, and myelocephalus. Trap denotes a common pathophysiology for all types of acardiac twins and also explains how the different gradation of abnormalities can be produced. So what are the complications of within the perfused twin? There is no ex utero survival. There is severe edema due to lack of excretory system, labor dystocia, cardiac failure or high drops, polyhydramnios due to high cardiac output state in the pumping twin. So there is labor dystocia, cardiac failure or high drops in pumping twin. Polyhydramnios mortality rate is 50 to 70%. Preterm birth rate is 25% in the pumping twin because the A cardiac twin is already dead. Then what are the management options? Management options include acardiac, polymer cardiac function. So the management is dependent on the cardiac function. Increasing volume of cardiac strain, then fetal intervention is done, and if small size और कोई strain नहीं होता है cardiac side, तो हम conservative management करते हैं. Current management rationale क्या होता है? Treat करेंगे all babies between 13 to 16 weeks of gestation. So what we can do, because there is arterioarterial anastomosis, so we can occlude that arterioarterial anastomosis through cord occlusion by intrafetal laser, radiofrequency ablation, or bipolar cord occlusion. So these are the ways through which we can do cord occlusion. Then what is SFGR? SFGR is selective FGR. It is a complication of monochorionic twin due to unequal placental sharing. So one scan is used to demonstrate unequal placental sharing, and it is known as placentogram. Now, placental sharing depends on placental cord insertions. So, this is central cord insertion, this is central and marginal cord insertion, and these are marginal and central cord insertion. So, filamentous and central cord insertion. So, this is marginal cord insertion. Can you see this? And this is central cord insertion. So, filamentous cord insertion has a stronger association with SFGR and discordance between the twins. Now, what is the management of selective FGR? Selective FGR in these cases, first of all, we have to rule out twin-to-twin transfusion syndrome. And if in a setting of twin-to-twin transfusion syndrome, selective FGR is present, then we first treat twin-to-twin transfusion syndrome. Now, we have to classify selective FGR into three types based on distinct pattern on umbilical artery flow Doppler. There is type 1, type 2, and type 3. In type 1, there is positive and diastolic flow. In type 2, there is positive absent reversed and diastolic flow, and is type 3 intermittent absent or reversed and diastolic flow. So management is tricky, best left to a fetal medicine specialist. So this is better and this is the worst, because intermittent absent and reversal of flow cannot be predicted in type 3 or intermittent pattern, while it is predictable in type 2 or positive absent or reversed diastolic flow. Now coming to fetal demise. If co-twin has already died, then risk in monochorionic twins is 15%, and if dichorionic twins are present, the risk is 3%. The risk of preterm delivery, if one twin has already died, in monochorionic twin it is around 70% and 54% in dichorionic twin. Neurological morbidity is 26% and 2% in dichorionic twins. So every abnormality is higher with monochorionic twins if there is twin death, preterm delivery, and neurological morbidity. Between monochorionic and dichorionic, monochorionic poses a complete different set of challenges, so surveillance has to be different. Now coming to time and mode of delivery, be careful about monochorionic twin starting from 14 weeks, as complication can set in or progress rapidly. So we have to monitor these monochorionic twins more frequently as compared to dichorionic twins. So, interval between two scans in monochorionic should be closer than in dichorionic twins, and effective therapy is available if complications are diagnosed on time. USG follow-up should be done every 2 weekly in monochorionic twins. So, this is the chart. So, in both these pregnancies, first of all, we have to decide for chorionicity at 11 to 14 weeks of gestation, which denotes dating, labeling of pregnancy, chorionicity, and screening for Down syndrome. After 11 to 14 weeks scan, we used to call the patient at 16 weeks, means after 14 weeks, after 2 weeks, we have to call the patient, and every 2 weekly, we have to do the scan till delivery to assess for fetal growth, ductus venosus, and umbilical artery PI and MCA PSV. While in dicorionic twin, we first do 11 to 14 week scan followed by level 2 scan, and then a scan is done every 4 weeks to assess the AFI and the fetal weight and other fetal Dopplers if needed. And then we deliver after 37 weeks of gestation. Here, delivery timings are also different. Now, what is discordance? When identical twins don't look identical, there is discordance. Either discordance in the size or weight, markers, like a bladder, anomaly, Dopplers, cord insertions, and could be an early pointer. Thank you.